trying to hit a snag here, but I'm back. Welcome. Thank you all for coming. And if you, Ashley, if you want to spotlight, no, I must look at the wrong view. Okay. All right. I am here. And welcome. As of course, we start 2021 with a little technical difficulty. I have a new studio here and new internet, so we're good. But as we launch, I just want to give a couple of quick tech housekeeping notes. You will notice that everyone is muted and you can't unmute yourself. We've had over 100 registrations and I want to keep the space safe for everyone. Later, we'll have a Q&A and you'll have an opportunity to ask questions using the chat function. If you, Ashley, if you want to share our first poll question, you can see how everyone is feeling as we begin 2021. So it looks like we've had most people join us. My name is John Beebe. I lead the Democratic Engagement Exchange in the Faculty of Arts at Ryerson University. And I'd like to thank the Faculty of Arts and Dean Sugman for helping to make this event possible. As I mentioned earlier, we're opening up the chat function now, and I hope you will take a moment to introduce yourselves and say where you're joining us from. I think we can close our sharing the poll results. So looks like most folks are feeling cautiously optimistic. Even have some folks who are hopeful and others who are realizing, understanding feeling things aren't looking great. One of the things that's been impressive is people's ability to remain cautiously optimistic through some really challenging times. So appreciate that. We can also now put up our second poll question so that we can see where, sort of sectors folks are joining us from. So if you take a second to fill that out. I also want to take a moment to introduce the newest member of our team, Ashley Denny. So Ashley, who will be moderating the Q&A, and she joins us from Athens, Greece, appropriately enough for our Democracy Dialogue series, where she is quarantining until she's given permission to return to Canada with her partner. All right, if we can close our second poll, and you can see we have a wide range of people from a wide range of backgrounds, and I think that is one of the strengths of this series and the strengths of our work is that we bring people together from different sectors. And for those of you who are not familiar with our work, our mission at the Democratic Engagement Exchange is simple: to build a vibrant and truly inclusive democracy in Canada. But that simple mission is not easy, and events in Washington and around the world are reminding us democracy itself is not an invincible force. At the Exchange, we are committed to bringing people together to engage democracy. People from all backgrounds and all sectors, scholars, community leaders, public servants, all with a shared commitment to fostering democratic engagement. If you're interested in learning more about our work, please visit our website at engagedemocracy.ca and follow us at RUEngageX. And if you believe that this work is important and valuable, please encourage your friends and colleagues to join us as well. We literally cannot do this without you and the people in your communities. As we launch this third season of Democracy Dialogues, I want to share a brief reflection on events that are rattling my country of origin, the United States. The recent failed attempt of a pathetic, malevolent narcissist to overturn the results of the presidential election directly led to a delusional mob storming the Capitol. As a consequence, 5 people are dead. But this is not the result of one leader gone bad. This is a result of decades of intentional efforts to undermine faith in democratic institutions. I had the privilege of working for the US Congress decades ago. It was a time before 9/11 when anyone could wander the halls of Congress, meet with their representatives and senators, and even dine in the quote members' dining room in the Capitol building. While it wasn't heavily advertised that anybody could go there, you could and have a wonderful sit-down meal next to all the leaders of the US. But it was also a moment when Republican leaders took a radical new approach to politics and set out to intentionally undermine people's faith in our democratic institutions. It worked. It turns out destroying institutions is far easier than building them. And last week, we saw the consequences as a mob stormed the US Capitol carrying flags with the name of the leader who first stoked their rage and then hid behind the walls of the White House. But that is not the only thing that happened last week. Last week in the state of Georgia, we saw Republican election administrators take a firm stance in favor of democracy against direct pressure from the United States president. And we saw a young Jewish documentary filmmaker and a brilliant Black pastor who preaches about the power of love and the importance of compassion elected to the US Senate. And this too was not the result of one leader or even a small band of activists. It was the result of decades of hard work by thousands of people maintaining faith in democracy, building democracy, even when that faith was tested by blood and violence. So that brings us to today. We are joined today by Cathy Crowe, and we'll put up a more fulsome link to her website in the chat. But Cathy joins us after having worked for decades to maintain and during that time, she has maintained her faith in democracy and worked as a street nurse confronting health inequalities alongside some of the most vulnerable members of our community. She has made sure that their voices were heard by our elected leaders. And I look forward to hearing more from her today as she talks about how she has maintained faith and how she has leveraged power for people who often don't have it. We're also joined by Dr. Danyaal Raza. Dr. Raza is a family physician who understands that the healthcare he can provide in his clinic in Regent Park is only one determinant of people's overall health. As a consequence, he is working to help doctors and other healthcare providers understand the importance of democratic engagement to people's health and to promote a more active role for healthcare institutions fostering democratic engagement. But before I turn it over to our guests, I would like to acknowledge that the land that I have the privilege to call home is sacred land. At the beginning of each session, we acknowledge that this area that we are working has been a site of human activity for more than 15,000 years. This land where I live and work is the territory of the Haudenosaunee nations, such as the Huron-Wendat, the Petun, and the Seneca, as well as the Anishinaabe, and most recently visited by the Mississaugas of New Credit. The territory later became the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Haudenosaunee Confederacy and the Anishinaabe to peacefully share and care for the resources and relationships around the Great Lakes. And in this moment, I am powerfully reminded of the wisdom of this covenant and that our presence here relies on all of us to take actions for the collective good. I am committed to doing what I am able to support my community in this time of great need and in the future so that generations that come after me can also enjoy this land. And with that, I would like to turn it over to Cathy Crowe to share some reflections. Just so folks know, Cathy and Dan are going to share some of their initial reflections for about 7 or 8 minutes each. We'll have a brief conversation with the three of us, and then we'll open it up to you for the second half of it to have Q&A that you will then submit through the chat. So Cathy, thank you very much for joining us.
Thank you. Thanks, John. Thanks, Ashley. So we all need a little bit of boost in our energies and our beliefs in democracy. And I want to read you a notation that I got in a Christmas card last month. It said, "May you recognize we all have the power to make a difference, not only in the smallest things in life, but the power to motivate others to believe in democracy and make a difference." And that really stayed with me because we're in very challenging times. So thinking about this, I wanted to tell you the story of how I became a street nurse and began working primarily with homeless people. I was working as a nurse, in a very hierarchical healthcare system, even in the community health center branch. It was seen as quite progressive. And a number of experiences that I write about in my book, my memoir, led me to go and work at a little organization called Street Health. And it was a very flat organization, very small. And interestingly enough, it was founded by a group of homeless men who called themselves the Balcony Group. And to show you how people can make a difference, these were guys that obviously had been socializing on a balcony, describing and being very frustrated with the barriers they had to healthcare and the stigma and discrimination they experienced when they accessed healthcare. So they lobbied and advocated, and one thing led to another, and Street Health was formed. It was and remains a very important organization. 50% of its board is composed of people who have been homeless or who are. Very grassroots, very responsive to changing needs. We as nurses were expected to, I guess you would say, enact democracy by speaking out. We were not prohibited or faced any barriers. Now, moving on a little bit, in the 90s up until the 2010s, it's hard to remember, but in Canada, we saw an enormous amount of democracy in action that included huge numbers of homeless people. There were rallies and demonstrations. There were formal deputations done at City Hall. Unions and faith groups provided massive support for those efforts. And politicians were routinely contacting us, keeping us up to speed on these issues and inviting us to participate or asking for our input. And I wanted to give you a few like really concrete examples of ways that we did the work. Excuse me. Over the years, we held a number of public inquiries and forums that were meant to include the voice of workers, but in particular, the voice of homeless people. One of them was called the Coalition Against Police Violence, and it was an inquiry into police brutality towards homeless people, some of which was done in confidence to protect people. Another inquiry was done into the conditions at Seton House, a large men's shelter, the largest men's shelter in Canada at the time. Another inquiry was done into the freezing deaths that were happening, and also another one into the the outbreak of tuberculosis that had occurred. And in common with these forums, we would have a panel that would include, a doctor perhaps, or a nurse, a politician, a journalist, but also a homeless person who was very grounded in the experience. And then it would lead to a report that would then lead to advocacy. Other activities we took were somewhat more fun, if you will, and we were using what was then new technology, which in one case was a faxathon. We did a faxathon to the Prime Minister's office where homeless people were sending faxes. Another time we did an outdoor microphone hooking up to a cell phone to call again to politicians. And at these events, we always provided a huge meal, also bus tickets for people to get back to their shelter or wherever they were staying at night. We did one remarkable event one day, which was a court case. We enacted really like street theater, a court case, which was taking the government of Ontario and the government of Canada to court. And again, we had somebody dressed up as a judge, and we had people enacting legal counsel, and all the evidence was brought forward, and it was a way that people could participate and describe their circumstances. And then there came a time when there was actually a constitutional charter challenge, because it was seen that both university students and homeless people were facing voter suppression. So there was a huge attention on a much higher level legally to deal with those issues. I experienced that firsthand when I ran provincially in Ontario for the NDP. And because of my career and the fact that the riding Toronto Centre had the most shelters in all of Canada, I just felt compelled that we had to have a staff person on the campaign that would be a homeless outreach vote coordinator. So we hired a man that had been homeless, who very popular, very well known, very articulate, and he did that role, which a federal candidate, Linda McQuaig, subsequently employed in her campaign as well. I have to say that we've also done some very direct action type events, clandestine type events that involved homeless people. And there's one that's very, very important, which was the time when Dry, who was initially very much described as a hermit who lived at Tent City on Toronto's waterfront, he became a very strong leader. And he did secret video footage in a basement shelter to expose the conditions that ended up, the images ended up being on the front page of the Toronto Star, and conditions at that site were immediately improved. And that video footage is in the film Street Nurse by Shelley Saywell. And I'll just kind of close with a really remarkable story that has links to today, which was the story of Tent City. And I link it to today's encampments, which we can talk about later if there's time. The story of Tent City was an example of a 3-year battle on Toronto's waterfront where 140 people were in an encampment. And when I link this to democracy, I remember the day that we at Toronto Disaster Relief Committee were asked by the people there to come in and help them to prevent eviction. And that led to a 3-year campaign of bringing in over 50 shacks and prefab houses, sneaking into the city's water supply for a very short period of time, bringing in portable toilets, but ultimately the leadership of Dry and others from Tent City led to a housing win. And that's, like, to me, that's the height of democracy, that those folks' activism supported by others led to the ultimate solution, which was housing for them. So I'll end there, but I do want to use one more second to quote Dry, who lived at Tent City. And he always came with us on our trips to Quebec City, London, Ontario, and places when we were having national rallies. And at Quebec City, he gave a 22-word speech in a blizzard outside. And he said, "We are all we. We need to convince the other we that we need help. We need housing. We need housing." And then he ended it with "Merci," and the crowd went wild. And I just think I've never heard anything so succinct. And sadly, Dry passed away a few weeks ago, but he's left a legacy. I'll stop there. Thanks.
Thank you very much. Yeah, those are very powerful words, and I think we're going to return to those stories, but I'm going to turn it over to Dan to talk about some of the research and work that he's leading on the role that healthcare providers can play in terms of democratic engagement. Thank you, Dan.
Yeah, thanks so much for the introduction, John, and thanks for inviting me today. I'm a little bit intimidated following Cathy because she's such a well-regarded expert in this field. But I think I'm going to compliment her here because Cathy, I think, has provided such a powerful narrative of what this health activism looks like on the ground. What I'm going to spend a little bit of time talking about is actually some research that I've been involved in that's actually looked at the question of, very explicitly, what do democratic engagement and a person's health have to do with one another? And I think for a lot of folks here, I saw the poll at the beginning. There's people here from the not-for-profit space, from academia, concerned citizens. There's a few folks out there who are also working in healthcare, and I think for those of us in healthcare, it's pretty strange for us to be thinking about, I think, democratic engagement within the institutions that we deliver healthcare in, whether they're hospitals or your family doctor's office. But it's also, I think, a little bit natural because we've arrived at this point through some gradual recognition. And really, it started when this idea of social determinants of health became mainstream, in medical education, in the medical community. I didn't graduate medical school, at least I don't think I graduated medical school that long ago. And when I did, we had like maybe 30 minutes in 4 years on it. But now, I mean, we have an entire curriculum in most medical schools focused on social determinants of health. I'm a family physician in the Department of Family and Community Medicine at St. Michael's. And for a number of years, we've gone beyond just recognizing that these are factors like your level of income, your education, your housing status. We've gone beyond just recognizing that these are important to the point today where we're actively intervening. So, for a number of years, we have this, a clinical income security program where we have health promoters who I refer my patients to, patients who have difficulty making ends meet, and these health promoters help people navigate and access, the complex web of social assistance programs. We have a children's literacy program. We have a health justice program, which is a partnership with some local legal aid clinics. We have a decent work in health agenda. And so, these are all upstream factors that drive health. But then the next question, also is what is the upstream causes of these upstream factors? And that's how we arrive to the question of what do healthcare institutions have to do with democratic engagement? And I'll say I've been very lucky to benefit from the experience and the mentorship of two folks who I just want to point out, Gary Block and Andrew Pinto, who are just not just national, I'd say international leaders on this. So it's under their mentorship that I'm able to do this work. So turning now to the actual research on this question, Andrew, myself, and the really fantastic medical student, Chloe Brown, wanted to see what did the research have to say about the links between voting and an individual's health. And we picked voting because the idea of democratic engagement, I don't need to tell people on the call today, is huge, right? It could be deputing at city council, it could be knocking on doors, it could be giving money to a little political party, it could be reading the news. But we picked voting because it's something that's measurable, something we thought there'd be some research on. And we basically did something called a scoping review to answer two questions. We wanted to know number one, what is the link between voting and health? And number two, is there any research out there that's actually looked at interventions that have aimed to increase voter participation through healthcare organizations? Like, is there something in the, the peer-reviewed academic literature? So we punched in all of our search terms into all of the research engines that, many folks on the call will be familiar with. We had over 2,000 results, but we whittled them down to the best 40 studies. And we looked at what those 40 studies had to say. And we found 4 key themes or key messages. One, there is a very clear association between voting and someone's health. So there is a relationship there. So that's very clear in the literature. And then the next key message that our finding that we identified was that differences in voting are associated with differences in health status. So I think most people might intuitively think, and the research confirms this too, that if you suffer from a mental health condition, if you have a disability, if you have other health conditions like heart disease, then you will likely vote, or at least on a community basis, you will vote at lower rates than someone who is who doesn't have these health conditions. And this is true in many different countries and many different jurisdictions, local, state, provincial, and national elections as well. So this is a reproducible pattern. But interestingly, we found actually there were some instances where the opposite happened, where if you had a state of ill health, if you were sick, there were some diagnoses where you would actually have a higher rate of voting, and most notably cancer. And this was really interesting and the hypothesis behind this is that the narrative that's built around cancer is one of, it's not an issue of individual choices or individual responsibility. We have this really positive and appropriately so narrative around cancer survivors and cancer heroes. So that can actually be quite empowering to someone who's struggling with their health conditions. It can actually increase social agency. And we know that a lot of patient advocacy groups that are focused around cancer are also really and appropriately really well funded. So there's this dichotomy that also relates to how we think about health conditions like cancer on one hand and depression on the other hand, that influence what we see when people vote. The third kind of key message is that, we know that voting and health are associated. We know that, for most folks who are sick, they vote in lower numbers. And the third thing is this difference, is it meaningful? Is it not meaningful? And yes, it is meaningful to the point where it can actually be related to electoral outcomes. There was this one, for example, there's this one study we looked at from a researcher in the US that looked at health inequality based on whether folks are racialized or not. And they looked at 30 years of data in the US from the 1970s to the 2004 election in the US, and for people who remember, that was the Bush-Kerry election. And in the 30 years that preceded that 2004 election, there were 2.7 million excess Black deaths. So what that means is folks who are African American were dying at a higher rate because of health differences, essentially due to systemic racism or racial differences. And that led to 1 million lost votes in the 2004 election. And while they concluded that wouldn't have changed the results of the presidential election, there were enough votes lost and in the way the votes were distributed that it would have actually led to different electoral outcomes for many state level races. And, we saw, John mentioned it off the top, we saw the razor thin margins of Georgia in the US. We saw razor thin margins in elections all over the US this presidential cycle. So what I'm talking about is not, it's not a throwaway phenomenon. And the final thing we found, and this answers our second question, is, what do we do about it? What can healthcare institutions do about it? And there are actually some interventions out there that have been evaluated that have found, a meaningful effect. For example, there was this one community health center in the Bronx in New York City that launched a voter registration drive. And of all of the eligible voters that they identified who were patients or clients of their clinic, they were able to register 89% of folks who were eligible. And, at St. Mike's and my family health team, we kind of test drove this concept. And part of the reason we did this research was to inform some projects that we wanted to do as well. And we used Ryerson's democracy toolkit to help us do this. We did this kind of in a small scale around the last provincial and last municipal election, but it was in large part because we wanted to have this research to inform that work and to drive further work within the healthcare system. So, this matters. This matters because these differences of voting and health have meaningful effects on electoral outcomes. It matters because if, as healthcare institutions, we care about social determinants of health, and I would say the changing language around it recently would indicate that we do, then we should also look at democratic engagement as a social determinant of health that we need to act on. And it matters because this is most salient for our patients who are already marginalized when it comes to the distribution of power and resources. And of course, we know much of the care that I'm able to deliver, whether or not my patients have access to paid sick leave, whether or not my patients have access to a public drug plan to a dental plan. Those are all decisions that are made by our elected officials. So these are meaningful differences, and who's involved in selecting our leaders that make these decisions is obviously, I mean, I don't need to tell people on the call today, obviously that's really important. And I'm just going to end by giving a nod, because I think it's worth recognizing that the community health center sector, which in Ontario has been around since the 70s at least, they've always explicitly had a mandate to focus on social determinants of health, and they've had a governance that has been community governed. So they've actually been doing work around democratic engagement, I think, more than any other institution, a healthcare institution in Ontario, and I would say in many parts of the country. But we weren't able to identify any of that work because we were looking at peer-reviewed research, which I think also speaks to the gap between, you know, what's the university community, what's happening in the folks who are doing the frontline work, and the bridges that we need to build to make sure that this gets disseminated more widely and that healthcare institutions take this on as a larger priority.
Great. That is a perfect transition. I just want to warn folks that it's windy where I am right now. So some reason that's impacting my bandwidth here. So I would encourage everyone to submit questions directly to Ashley, and so send them through the chat and she will queue those up and we'll turn it over to those questions here in a moment. But I also would be remiss if I didn't mention a couple of plugs that I should have been more explicitly, but for Cathy, Cathy, first of all, is a visiting practitioner at Ryerson University, and is a sort of colleague of mine within the Faculty of Arts. So we're very fortunate to have her there. And I think it speaks to both Ryerson's commitment to bringing in practitioners. I also am a practitioner. I like to call myself an activist in residence. But it's I think that kind of forward, innovative, not meaningful education that is provided and embraced by the Faculty of Arts and Ryerson more broadly. So thank you for that. And also, Cathy recently, well, there's been featured in a number of films, but she recently completed a great book, A Knapsack Full of Dreams, that speaks about her experience and as incredible sort of storytelling of her years of dedication to this work. So if anyone's interested in that, you can find links to that on her website that we've shared, but I wanted to make sure that people were aware that those resources are available. And we'll be sharing all of these resources more afterwards. I think you both have mentioned, there's one thing I wanted to follow up with. You've both mentioned sort of the challenge within our healthcare institutions. Cathy, you talked about how decades ago there really was in many ways more engagement, more democratic actions, and the whole community health sector. And I'd love to hear a little more about why you think that has sort of gone away. And Dan, this positive shift where, in our medical schools and in our institutions, recognizing the importance of social determinants of health, but at the same time, how our public health and our health institutions more broadly are reluctant to get involved in the fostering democratic engagement. And if you can talk to me, talk a little bit about your experience. Let me start with Cathy, maybe with your experience and where you see us now compared to where we've been, because you have this wonderful perspective, that you can offer us.
Sure. So in 1993, I was a street nurse at the corner of Sherbourne and Dundas, the epicenter of the homeless disaster in Toronto. And the federal government, two successive federal governments, canceled our national housing program. And when it happened, I didn't even know about it. There was no protest. There was hardly anything in the media. It just happened. And it happened because we let it happen. There was not a strong movement to protect it. And so that was a wake-up lesson for me. And it certainly has led to the mess we're in. But I want to bring up Mike Harris's name, not only because there's quite an outrage because he's being nominated for the Order of Ontario, but because when he became premier in Ontario in 95, 96, he really instigated, what we all now call neoliberalism and the policies of neoliberalism, cutting funding to social programs, facilitating privatization, et cetera, et cetera. And the damage that caused has led to a lot of the problems today, including Housing First policy, which is an American policy that Canada has now embraced to respond to homelessness, which means that all silos of government, many researchers, in fact, funding decisions are prefaced on a Housing First philosophy, as opposed to a solid social program like Medicare, which was our national housing program. I added a whole chapter in my book on that for folks that are kind of gurus around housing policy. I didn't ever want to write about it, but I had to. And I think when I compare today to then, we've been through the 2008 recession, and that had a large hit on social movements, on union movements. And again, Housing First policy has really diminished activism. So many of our national so-called housing advocacy groups now are very much, proponents of the federal government national housing strategy, which is a Housing First policy. It's not about a housing for all. And sorry to give another Toronto reference, but if you're in Toronto or if you've seen pictures, you just have to look at the sky, and all the cranes you see are condo development. And there's maybe only one, maybe two social housing projects being built. And that's because the federal government is not there on this issue. And of course, our province is not as well. I think BC and Quebec have done a little bit better. So there've been a lot of factors. And then I also think in academia, we're not teaching it the way we once did in the 60s and 70s. And we're not teaching necessarily the components of community development or activism. It's kind of a rare location where you see that. So that's part of the reason why I'm glad to be at Ryerson, because they're obviously open to this kind of learning. And certainly that shifting. I can name an academic in every university across the country who's a star in this, but it's overall, especially in nursing, not filtered down into programs. Everything I talked about earlier, I learned way after I graduated from Ryerson, and I learned it from grassroots street outreach workers. So I think there's a lot of factors, and I think there's signs with COVID, things are changing, and I can talk about that later.
Dan, do you want to take a moment to just talk briefly about your experience within, the institutions, the healthcare institutions that you're working with? You mentioned the community health centers, but what about other health institutions? What has been their reception to your research?
So I'll say the biggest barrier has, in my mind, has already come down, and that's the barrier that was preventing healthcare institutions from engaging on work that sought to do something about social determinants of health. And that has become, I think, more of an accepted idea. At St. Mike's, that started with our income security program, and that's kind of been the leading edge of the wedge. And we've seen that start to disseminate out, across the country, to mostly in primary care, where I think it makes the most sense. But we've begun to that's kind of been the thing that's gotten out. Once that barrier came down, or has started to come down, it's allowed us to explore these other areas. So I think now it's just a matter of putting a project out there, seeing if it's going to work or not, how is it going to work, in a healthcare setting, and then disseminating it. And then I think if other healthcare institutions see you see a best practice, I think because the biggest barrier has come down, I'm fairly confident that we would see a dissemination of this sort of work. But one thing I will also say, and this speaks a bit to what Cathy said, is there's also risks in doing this, right? Risks in not just talking about democratic engagement as a responsibility of a healthcare institution, but other social determinants of health, and that's that we medicalize these issues. Because these are also interventions that act on individuals, right? But we know that if we want to improve democratic engagement, things that would make a much larger difference are things like a per vote subsidy or, other systemic level things. Just like with income security, it's great that I can help patients who have difficulty making ends meet through the health promoter in my clinic, but raising the minimum wage sure would be great. Raising the rates of social assistance sure would be great. Having paid sick days sure would be great. So I'm really excited about this work, but the risk is that we medicalize it and it potentially, and I don't think this is happening, but it's something that I'm always aware of, that it potentially takes energy away from this really important larger systems work.
Can I make a comment on Dan's point? I think if you watch any of the news media right now with respect to COVID, you'll see terrific examples of physicians doing just what Dan was saying, talking about the need for paid sick days, talking about crowded housing. And like for me, I've been like really thrilled to see that, and I keep retweeting and talking. So it's just like routine now that we're hearing physicians talking about these issues. So just to reiterate that, I'm really happy about it, because I began working in the days of Philip Berger and Michael Rackless, two doctors that were really prominent Canadian activists. And to me, it's optimistic that there's like a resurgence of that kind of advocacy right now for health.
Yeah, and lots of follow-up questions I'd love to ask, but I want to make sure we get to our people who've joined us, the questions from them. So I'm going to turn it over to Ashley to ask some questions from our participants who are with us today.
All right, so the first question is from Jackie, and she's asked, what would it take to politicize healthcare professionals? I'm intrigued by a group that has so much autonomy, power, privilege, and knowledge is absent in large numbers from progressive social activism. So what are both your thoughts on that?
Well, I think the physician medical education is doing a great job. I think nursing is far behind. And, I think community health placements for nursing students have to be not in long-term care, although I realize they're needed there now, but there needs to be courses in, politics 101, economics 101. These should be compulsory courses. So there needs to be some radical change. And I think with virtual learning, there are huge opportunities for that to happen. Social determinants of health is taught in nursing, but primarily as an academic lesson. And in my experience, people's eyes glaze over, and it's not enacting it in life the way that Dan is speaking about, and that I've tried to do as well. So we still have quite, this might be not a polite thing to say, but we still have quite a conservative leadership in nursing, with a few great exceptions, such as the Canadian Federation of Nurses Unions and Doris Grinspan and RNAO, and the UVic Nursing School is fabulous. But we need to, people need to read my book. I'm sorry to keep plugging it, but I have a whole section in it on nursing education and what needs to change.
So I'll say that similar to, I think, what Cathy was saying, as a profession, physicians are definitely, I'd describe us as a group as small c conservative. Okay. That being said, we're seeing a level of activism, of progressive activism within the physician community that I don't know we've ever seen in Canada. And I think that's for a number of reasons. One is there's been an increasing move in medical education to have medical students, and then of course, eventually physicians in Canada, be more reflective of people in Canada, as opposed to, high income, coming from high income white families. So we're starting to see that shift, and I think that's influencing the type of activism we're seeing. And we're seeing it in actually all sorts of different ways. So for example, I'm the board chair of a group called Canadian Doctors for Medicare. There's the Canadian Association for Physicians for the Environment. There's Doctors for Gun Control. There's the Decent Work and Health Network. And, you know, when Cathy was talking about Phil Berger and Michael Rackless, who are kind of like, you know, the people who started this for many of us in the 60s and 70s, but there was like one group, like they were the group. And now we're seeing so many other, you know, issue-specific groups come up. My medical association, Ontario, is the Ontario Medical Association. And I mean, the OMA still has, I would, by no stretch of the imagination, would I describe the OMA as a progressive organization. I mean, if I do one day, then you have to pinch me and wake me up or resurrect me if I'm already dead. But they're talking about climate change and health. They're talking about the inequity in terms of gender pay within the profession, which is huge. Because, you know, the organization that I'm the chair of, Canadian Doctors for Medicare, we were started in 2006 in response to the election of Brian Day to the presidency of the Canadian Medical Association, who is a well-known advocate for increasing privatization of healthcare. So the organization that I lead now is a direct response to that. And you know, since 2006, the landscape in the physician community has changed. But one other thing I'll say about this, I think physicians are in a unique position to do this because we are not employees of hospitals, right? We bill OHIP, we bill Ontario. So even though I work at St. Mike's, I don't get a T4 from St. Mike's. So that gives me an incredible amount of autonomy, in addition to the social capital I have as being a physician, that other healthcare workers don't have. So it's not just, you know, what we're doing now is not just a reflection of where you know, how things are shifting in terms of attitudes, but it's also a reflection of the, you know, the autonomy and the social privilege that we have.
All right, thank you. So I'll go to the next question. There's a ton of great questions, so thank you to everyone and keep sending them. Next question is, it's from Tara. What has been your engagement with Indigenous communities given the systemic racism that they face in our healthcare system, which then exacerbates their non-engagement in our political process? So for both of you, Dan, I don't know if you want to go first.
Sorry, Ashley, I'm happy. I think were you saying?
If you want to, or Cathy, sorry, whoever would like to cover.
I'm happy to go first.
Sure.
I mean, I will say historically, it's not been very good. But at least in our department, we've been making reconciliation a central part of how we're rolling out services. I will say I'm not the person who's centrally involved in this, but things that we have been doing are engaging in programs around cultural safety training, where we're recruiting healthcare providers that are reflective of the communities that we want to serve, including Indigenous healthcare providers. So I'd say we're in the very early stages of doing this. So I don't think we're by any means a model, but we are engaging in the work.
For myself, it's been primarily through many Indigenous people being patients. I worked for 10 years at Queen West Community Health Center in Toronto. It was very shocking actually to see the percentage of the homeless population that was Indigenous. In my first book, Dying for a Home, I made sure to profile a very prominent Indigenous man. He's passed away. His name was James Kagoshima, who was quite a leader. And of course, working with Anishinaabe. And I think in later years, it's been more focused on provincial advocacy through my provincial nursing group, to ensure that the recommendations on nursing education from the Truth and Reconciliation Commission are respected and enacted. That's what I'll say.
If I can just add, two folks who are in our department who I think are doing amazing work on this are Janet Smiley and Suzanne Shush. They're both physicians who are Indigenous, and Janet has an incredible research agenda on this, and Suzanne is really pushing it in terms pushing us to do better in terms of our clinical service, but also in how we deliver medical education. So I would suggest you type those names into Google if you're looking for folks who are really role modeling what we need to do.
Another great question, kind of a big one. It's from Rana. In the current atmosphere where most privileged people know and demand their rights, but choose to ignore their responsibilities, how do we ensure rights for those of us who can't speak out as forcefully? We know about the SDOH and homelessness, but how do we involve the general public in this more forcefully?
Wow, that's the number one challenge today. Most of the advocacy groups really don't have funding. It's very rare that a strong advocacy group receives funding. That's kind of a relatively new phenomena. And I would say during COVID, there's a whole bunch of things that have happened that are restricting possibilities of reaching out to people. Obviously, physical distancing, the fact that city council and other meetings are virtual, but only audio. Funding issues are restricted. It's very, very challenging. And it's weird to say, but I do most of my advocacy trying to reach groups right now on Twitter, and I do as many invitations to speak as I can. I think there's a huge shift in that people are way more concerned about these issues, like the average person, if there is such a thing, is way more concerned about these issues than before, but we're in a place where it's hard to influence. And people want to believe the best. People want to believe that their local city councillor or their MPP, who's so nice when they meet them in person, or their MP, they really want to believe that that person is doing the right thing. And that is absolutely, with the rare exception, not the case right now. So it's very hard to get past that notion of what elected officials are doing or not doing. And also because, and again, I would say with the exception of Quebec, as a country, Canadians, people living here are not really, they're not really taught to be forthright politically. So I feel like I'm always kind of training and trying to teach people, yeah, you can call your city councillor for this. You can speak to their EA. You can, because their voices are actually going to make a huge, huge difference. So right now, the emergency I'm dealing with right now with others is the fact that on the weekend at 4 a.m, our city allowed the removal of 2 physical wood shelters and a tent and people's belongings to be taken by city workers from an encampment. Many people are not going to really believe that they would do that, but they have. So it's kind of, it's very, very challenging. And we have no, I will say in Toronto at the city level, we do not have a champion that is also trying to engage the general public for the most part on these issues. So it's the number one challenge right now, because it will only be when that level of voices are heard that politicians will respond, or bureaucrats.
Maybe I can cheat a little bit and answer that question within kind of my world in healthcare. I don't think it's any surprise to anyone that healthcare has traditionally been a pretty paternalistic experience, you know, when you walk in to see your doctors and the visit that happens. But I think there's been some very meaningful change where we're becoming more patient-centered and more collaborative in the way that we do care. And what we're trying to do now is not just do that in our one-on-one encounter with our patients, but also in the way that we think and we design our services. So for example, in my department, we have a committee that looks at our SDOH programs, and we've incorporated very explicit patient input. So it's not just based on kind of our second-hand knowledge, us translating the experiences of our patients, but we have patients more directly involved. And it's not just about putting out a call for volunteers and patients to come join us, but it's also asking, okay, well, who's responding? Are they the folks that really represent the entirety of our practice, or are they just the people who have the time and the childcare, et cetera, to do it? And so we're also trying to build in supports to help facilitate people who wouldn't ordinarily be able to come and provide us this sort of consultation. So it's in that way, we're trying to be more responsive and reflective of our community and allowing people to assert their needs as opposed to us inferring what they might be.
Great, thank you. I think one more question we probably have time for. So this one is from Suzanne. What do you each think is an effective strategic alignment between a nonprofit serving people who are homeless and acute care, the home of much power and influence within healthcare?
Well, in the past, I've seen examples of acute care hospitals having a community advisory board, specifically on homelessness, so that community providers can bring issues and trends and worries that they're seeing to get solved. I've also seen both the old Wellesley Hospital and St. Mike's employ a homeless advocate in their emergency department that was a peer worker. So there are a number of initiatives like that. St. Mike's has the Rotary Center, which is a kind of a pause between being in emerge and heading back out to the street where somebody can rest. So I think there's a number of initiatives. We used to do community walks to train every new employed Wellesley Hospital worker to the issues of homelessness by taking them out on a walk. There's a lot of creative activities like that that I think could take place. But first and foremost, I'll give you an example from this week. I was lobbying to get the CEOs of all the hospitals in Toronto anyway to speak out on the fact that they cannot do everything for long-term care, that long-term care needs a huge funding boost because all the problems in long-term care were being kind of blamed that, oh, the hospital has a partnership here and they'll fix it. Well, we need the CEOs to speak out. So having that advocacy is really important.
Yeah, I mean, I'll just add a couple other examples into what Cathy mentioned. I think there's some really exciting healthcare organizations that are making that, trying to bridge that gap. So there's this family health team in Toronto called Inner City Health Associates, and they are providing primary care in shelters, for example, and they're the bridge between acute care and the nonprofits that are running the shelters. And then there's also this really exciting program that's delivering palliative care to people who are homeless called Peach. And they're also making that bridge between people experiencing homelessness, acute care, and they're even in the process of setting up a hospice for folks for whom that makes sense, who are homeless, and doing that within a not-for-profit model. So there are these examples that are creeping up. And I think the challenge with anything in healthcare is we're really good at coming up with these, really exciting programs, but the part where we struggle is the spread and scale. And I think that's what we need to do next.
And I think that's a good note for us to we could continue the conversation, and I hope we will in our various forms and ways. And now that folks are aware, for those folks who are just meeting Dan and Cathy for the first time, please stay connected to their work, because that's what's going to take all of us working together to strengthen these connections and build on this work for the long haul. But I'd like to also just very briefly, and one sort of more fun note, all of us are spending a lot of time these days, at least I know I am, watching interesting things on our screens in the evening or in our free times. And Cathy is an incredible film buff. And not only is she featured in films, but she is a font of knowledge of film. So I'm going to ask for 3 recommendations of things we should be watching, and then turn it over to Dan for 3 quick recommendations as we wrap up here of what we could all be watching in our free time.
Okay. So first of all, it's a really, really old documentary. You can find it online. It's called If You Love This Planet by Terry Nash. It's really old, but it's really important, and it changed my life. Second is Crouching Tiger, Hidden Dragon by Ang Lee. And it's all about wielding the sword, which for me is a metaphor of wielding the sword. I'm sorry, it's a military term, but wielding the sword of advocacy. And in that chapter in my book, introduced by that film, I talk about all the strategies I've used. And then third is one that, wow, it's so fitting for this time. It's Ken Loach's film, Sorry We Missed You, that is about precarious work. And when you watch it, just think Amazon delivery and think PSWs. That Ken Loach film is a must-see. And I think it came out in 2019. That was a fun question. Thank you.
Thank you. Dan?
Okay, so I actually thought more about this than I anticipated I would, but all three of my recommendations are animated. They're all cartoon, which I think is reflective of my family makeup. So number one, Danyaal Tiger. It's a show for kids. It's a Mr. Rogers spinoff. And I bring it up because the most recent episode is this amazing episode that breaks down, like, for kids, how to deal with pandemic and social distancing. And I watched it last night with my daughter, and oh my God, it was hard for me to keep it together through that whole episode. The second one is a movie folks may have heard about recently called Soul, which we watched at our last pizza and movie night, family pizza and movie night, which is like, you know, it's pretty ambitious. It's a Pixar movie about the meaning of life. But I think at a time when a lot of us are kind of reevaluating things, it kind of hit the right spot. And the third is an adults only thing. It's totally vulgar, but it's so good and explores topics from, you know, sexuality to, you know, relationships, and it's all about going through puberty. It's called Big Mouth. It's on Netflix, and I was a bit hesitant to talk about it because it is so vulgar, but it's so good, and it's like Degrassi, but vulgar and animated, and it's great, and it will, and it's you know, wellness.
All right, so we have our watch list for the next week, and I just want to again thank both of you for taking the time to join us, for just being role models for all of us in your work and your leadership, and you know, and look forward to the chance when we can be together again in the same space to work to continue to do this work together. I also invite everybody to join us. We are going to now hold our Democracy Dialogue sessions on the first Tuesday of every month at around this time. Our next session is Empowering Through Accessibility Towards Inclusive Democratic Engagement for People with Disabilities. And we're going to have an incredible leader, Gary Malkowski, who is a former Ontario MPP member, the first member to deliver a speech using sign language in the Ontario legislature. And I think anybody who is interested in expanding engagement will be very interested in that session. And then we have another one scheduled for March about the role of post-secondary institutions in strengthening democratic engagement. So hope you can join us for those. Again, we will be sharing more resources for everyone who's here today. And you know, want to wish everyone well in these very challenging times, and appreciate the fact that you've showed up today is a great sign of what can happen and how we can build community. And I look forward to seeing you all in person at some point that I don't know when. So with that, we'll let everyone go, and we will hopefully, you know, be in touch.